This presentation will discuss some of the disorders of the pericardium, including pericarditis, pericardial effusions, and pericardial tamponade. So it's first important to understand what the pericardium is and what its typical functions are. So the pericardium is a double-layered serous membrane. So you can kind of see it here. So up in the left-hand corner is the heart, and we've zeroed in on this portion of the ventricle here to show kind of the different layers. So you have the endocardium, which is a kind of the inner layer of the heart itself, the myocardium, which is the thick muscular layer that makes up the heart wall. And then you have the epicardium right here. And that is a visceral layer of this serous pericardium that covers that muscular layer. Next, you have a pericardial cavity, and this is a space between two membranes, the epicardium and the parietal layer and fibrous pericardium. So in between the epicardium and the pericardium is this pericardial cavity. And it has serous fluid in it that helps to lubricate and prevent those layers of epicardium and pericardium from rubbing together while that heart kind of expands and contracts. So normally, again, there's this cavity that is fluid filled that helps to lubricate and facilitate movement of the myocardium. Other functions of the pericardium: it isolates the heart from other thoracic structures. It helps to maintain the position of the heart within the thorax. Having this fibrous pericardium layer prevents the heart from overfilling. It gives it kind of a limit to how full it can fill, which is important. And it also contributes to the coupling of the distensibility between the two ventricles during diastole, meaning that they can both fill equally, again, because it's surrounded by this fibrous pericardium. And that's also important. So if you kind of look at those things, the definition and the function, many of them outside of kind of the separation and positioning piece are really about how the heart fills, how those chambers, experience kind of equal filling, how we don't overfill, but also allowing it to fill, in the sort of correct amount to maintain good ventricular functioning. So when we get pericardial disorders, there are kind of three large categories of pericardial disorders we might see. One is a pericardial effusion, and that is accumulation of fluid, can be pus, blood, or just regular pericardial fluid within that pericardial cavity. So that normal space starts to fill either with excess fluid or with fluid that doesn't belong there, again, like pus or blood. That can lead to a condition called cardiac tamponade, which is a slower rapid compression of the heart due to accumulation of fluid, pus, or blood in that pericardial sac. So pericardial effusion can lead to the condition called cardiac tamponade. We can also experience pericarditis, which is an acute inflammatory process of the pericardium. But pericarditis can also be chronic in nature, where someone has this condition for maybe more than 3 months. It may go beyond, any infectious process or any other cause. And there's also something called constrictive pericarditis, which I'm not going to really talk about too much. But in the cases of things like chronic or constrictive pericarditis, those patients may need maybe an additional surgery or something to what we call a pericardial window, where we open up a little space to relieve some pressure over time. But we are going to talk a little bit more about specifics of acute pericarditis. So the picture on this slide, you can see this is a normal heart, normal pericardium, but in a pericardial effusion, you can see that this space, this is the pericardial cavity here, This space is filling up with fluid. Again, can be just regular pericardial fluid or it can be blood or pus. And it's starting to press down or compress the heart itself within that cavity as that fluid-filled cavity increases in size. So we're going to start with a discussion on acute pericarditis. So acute pericarditis is an acute inflammatory process of the pericardium. So usually when someone has acute pericarditis, we diagnose its presence based on this very specific triad of clinical manifestations that we see. One piece is largely by EKG. We can also look at radiography or echocardiography to appreciate the changes to the pericardium itself. But a quick way to do this is on EKG. And I have an example of an EKG on the right from a patient with acute pericarditis. And I know you guys haven't had too much about EKG as of yet, but what I'll show you on this EKG is that in every single line, right, in every single portion of this EKG represents a different lead or electrode that we put directly on the patient's chest. And what you're seeing from every single electrode is this elevation in what we call the ST segment on the EKG. So here's elevation here. This looks odd in here. Every single lead has what we call ST elevation. And that is very indicative of acute pericarditis. We'll talk about ST elevation again when we get to myocardial infarction, because that's also one of the things we look at diagnostically for heart attacks. But it's very different than what we see in acute pericarditis, because in a heart attack, we usually see this elevation or these changes to the ST segment maybe in one or two leads, maybe three on an EKG. But the fact that it's on every single lead is usually indicative of acute pericarditis. So that's one of the main ways we can diagnose based on clinical manifestations. Others is the presence of a friction rub. So that is something that you can auscultate on the chest with a stethoscope. You place your stethoscope on the heart, and when you're listening, you hear kind of a rubbing or almost a squeaking sound over that heart muscle. And that's happening because of that inflammation in the pericardium is causing, instead of that kind of good frictionless surface that we normally have, now that inflammation is causing kind of a friction sort of rubbing together of those epicardium and pericardium that we don't normally have. And you can hear that through your stethoscope as a friction rub. And the final piece of that clinical manifestation triad that we see in acute pericarditis is chest pain. And it's usually chest pain that's very abrupt in onset. So your patient would report it just started suddenly with no previous pain. And they usually, if asked about quality of that pain, call it kind of sharp, and it's usually relatively severe. So those three things together are very indicative of a diagnosis of acute pericarditis. Other things you might see clinical manifestation-wise, on laboratory markers, you might see signs of systemic inflammation, maybe an increase in white blood cell counts, an increase in C-reactive protein or CRP, or an increase in erythrocyte sedimentation rate or ESR. So there's a little bit of chronic pericarditis stuff here. We kind of already talked about that. No identified pathogen. It usually lasts more than 3 months. One of the common causes of chronic pericarditis are things like autoimmune disorders. Things like lupus often cause this. So that's one of the differences. Treatment for acute pericarditis. We often just use anti-inflammatories, things like NSAIDs or corticosteroids might be helpful. If it's pericarditis being caused by an infectious process, we might use antibiotics to clear the infection. So those are the typical ways that we would treat an acute pericarditis. So a little bit more about cardiac tamponade, which again is that condition that can occur when someone has a pericardial effusion. So a pericardial effusion can lead to cardiac tamponade. And tamponade is a compression of the heart due to accumulation of fluid, pus, or blood in that pericardial sac. And so you can see that here in the picture, normal healthy heart on the left, and here's tamponade on the right, where we have this significant accumulation of fluid in that pericardial sac, and it's pressing down and causing significant compression on the heart muscle itself. Common causes of effusion that can lead to tamponade are things like infections, neoplasms or cancers, or bleeding into that space. I've dealt with cardiac tamponade once in my career, and it was caused by a procedure where we poked a needle through the atrial septum to do some cardiac ablation. And that patient was on blood thinners and ended up bleeding into that pericardial sac from that procedure itself. And they experienced cardiac tamponade because of a filling of blood. You can also see it in maybe traumatic events where someone has maybe a significant kind of blow to the chest where blood can kind of fill up in that cavity. They may end up with something like cardiac tamponade. Post-cardiac surgery, you can fill with blood. It's just a little bit of discussion right on the etiologies there. So a person with cardiac tamponade, some of the significant clinical manifestations we see a reduced stroke volume and then overall reduction in their cardiac output. This is because all this pressure and pushing on the left ventricle increases what we call the intracardiac pressure filling limit. So as that compresses, there's this high pressure situation that starts to develop within the heart itself. And for the heart to be able to fill, it needs to be a low pressure environment so that blood can flow easily into the ventricles. And so if we increase the pressure, they don't fill very well. And if we don't have good filling of the heart, there's not enough blood in there to eject well during each heartbeat. And that's what stroke volume is, right? If you remember, stroke volume is the amount of blood ejected with every heartbeat. If we can't fill the heart with blood because there's so much pressure, we're also not going to eject much blood because it didn't fill in the first place. So we see again a significant reduction in stroke volume, and that leads to a reduction in cardiac output. And reduced cardiac output reduces blood flow to all the tissues in the body. So we see wide-ranging potentially clinical manifestations based on that low perfusion volume, right? We might see neurological stuff like confusion, restlessness, maybe eventually loss of consciousness. We might see, damage to the kidneys, any of the things that go along with low perfusion to the tissues. Other things that happen, patients experience tachycardia and increased contractility of the heart as all of those systems within the body that sense low volume start to be activated, right? So if we have now we have baroreceptors that are sensing low volume, and they react by signaling the sympathetic nervous system, and that sympathetic nervous system activation will increase heart rate and contractility in an attempt to increase cardiac output. So these patients' heart rates will go up, they'll feel like they're beating harder, right? But because their heart isn't able to fill, that blood is going to start to back up into the venous side of the body. So you'll see things like jugular venous distension in these patients as that blood starts to back up. Hypotension also occurs as your cardiac output reduces. We hear muffled heart sounds. So if you listen to the heart sounds, they'll sound kind of far away or quiet. And they are further away, right? We have all this kind of fluid in between where we're listening and where those heart sounds are being produced in the, that valve closure piece. So they do sound kind of quiet and farther away. If we do not relieve that pressure of cardiac tamponade, patients can experience circulatory shock. And we're going to talk about shock as well in this unit. So you'll kind of learn what that looks like. But that's a significant sign and symptom that would indicate this needs to be treated or alleviated quickly. So another thing that we often see in cardiac tamponade is something called pulsus paradoxus. So this is, by definition, an exaggeration in systemic arterial pulse volume with respirations. So normally when we breathe, there's a decrease in intrathoracic pressure. So the pressure inside of the thoracic cavity will decrease during inspiration. So when we breathe in, the pressure within our intrathoracic cavity decreases. And as that pressure decreases, it makes it easier for the right ventricle to fill. So that breathing in accelerates or speeds up venous flow as well as speeding up right heart filling. And then the intraventricular septum also kind of bulges into the left heart. So we see a decrease in left ventricular filling, also stroke volume and systolic blood pressure. So you can kind of see on the picture, the top is what we see in normal expiration and inspiration. So during inspiration, the pericardium and normal size. So expiration and inspiration here lead to that, ease of right ventricular filling. Okay. In tamponade during inspiration, um, the arterial pulse becomes weakened or absent, and then even stronger during expiration. So that is one of the diagnostic measures we can look for with cardiac tamponade, are those significant changes that we see to arterial pulse during inspiration and expiration. So again, arterial pulse gets really weak or absent. So if you were palpating someone's radial pulse, and they took a deep breath in, you might not feel that pulse at all. It would become absent. And then when they breathe out, that pulse would become much stronger or potentially even bounding. And normally for people, when you're, palpating a peripheral pulse during inspiration and expiration, you don't really appreciate too much of a difference in that pulsation during inspiration and expiration, but that changes significantly in cardiac tamponade. So if someone is experiencing an effusion or tamponade, treatments here are similar to what we see in pericarditis. So you might use NSAIDs or other anti-inflammatories for mild cases. If the underlying problem is an infection, you might use an antibiotic. In more severe cases, you may need to drain that fluid from that pericardial sac. We call that a pericardiocentesis. It can be done surgically, where you open the chest to drain the fluid, or it can be done percutaneously, where a needle is inserted into the chest, into that pericardial sac, and we literally just draw back that fluid. So you usually insert the needle. They often have, like, you can put an electrode or something on the needle. What you're looking for is picking up any electrical activity, because you want to get that needle into the sac, but you don't want to hit the heart. So you're inserting that needle. If you notice any arrhythmias while you're doing it, you pull back a little bit until you just draw fluid kind of directly out. You can use ultrasound guidance to make sure you're in that space, but that's how you would do a pericardiocentesis, to directly remove that fluid.